I'm Greg Worrell, and this is about devices for making life easier. And what what we have for a lineup is we've got 4 speakers. So I'll talk a little bit about devices. Geeta Gupta will talk about devices for sleep. Michael Schechter will talk about pulmonary devices. And to kick things off, we have Jeannie Schnur, who's going to tell us a little bit about her experience with one of the devices that's pretty widely used. I did a little survey of I'm an adult epileptologist. I did a little survey of my colleagues in pediatric epilepsy and asked them, which of these devices do you guys recommend, do you use? And the SAMI device was one that people have found to be very, very useful. So I'll give Jeannie a chance here to tell us a little bit about her experience with that device.
Awesome, thank you. Welcome, everybody. My name is Jeannie Schnur. I live in Virginia. I have 3 children. Jackson is 16, Tenley here is 15, and my youngest son, Bennett, is 11. Our oldest has LGS, and for a long time, probably since he was 4 or 5, his seizures have been occurring during sleep. And so that's challenging because we all want to be sleeping during that time. But obviously, if he's seizing and having tonic seizures, it is very concerning. We don't want to miss one. We are obviously concerned about SUDEP. And so a couple of years ago, we applied to the LGS Foundation and were able to get the grant through the Elevate Patient Assistance Program. And so the SAMI device has been a real game changer for us. So it's a camera, and this camera is mounted inside of his bed. He does have a enclosure bed, so it's the Courtney bed. So that camera is mounted in there, as well as an IP camera that we just use, and we can pull that footage up on our phone at any time. But the great thing about the SAMI cam is that it records movement. The downside is that any movement that happens is being recorded. So one, parents are always recorded. So like some of these videos I have to screen before I show to anybody else, because who knows what you're gonna see overnight when parents are sleeping in the bed. But the footage that we've been able to get, we are able to then show our doctors like, hey, this is what's happening. And over time, obviously, we have lots of different seizures. They present differently. And specifically for Jackson, this past year, his seizures have changed in duration and frequency. And so being able to show like this was happening at this time, but now this is happening is really helpful to our neurologist. The other thing is that we can use that data to input into our seizure tracker app. Is anybody using seizure tracker app? Raise your hand. Just 1, 2. So this is another great tool to use, not necessarily a device, but an app that you can get, and you can put in every time your child has a seizure, and it can be as detailed as you want or not. For us, at this point, we're just putting in the length of seizure and the time of day, and if he was awake or asleep, because that's important to us. And then we can use all of that data. It can be downloaded. You can have charts. You can have graphs. You can see time of day. And it's very helpful to have that as you're making med changes. There is one other device that we are using now. Recently, we had to get a pulse ox and oxygen because of a hospital stay that he had, and he had some issues with his breathing in the hospital. So we got that pulse ox, and that's also an alert that is showing us heart rate and oxygen levels. And so that will set an audible alarm when it gets either too high on the heart rate, too low on the oxygen. And we hear that. So I don't necessarily hear Jackson get up out of bed, or really his seizures don't make any sound. So it's like, how do we know if he's having a seizure? If I hear that alarm, I'm knowing something's happening and I'm down there. He's also on our main level of our house now. He used to be upstairs. So having these different devices is really helpful. If you have specific questions, I can show you like what it looks like on my phone. Like we can get it on phone. It comes on the iPad. I think pulse ox. That's your measuring your oxygen level. Yeah. So we don't use that one anymore because it's not as reliable as the hospital grade one. So we got that through the hospital. But there are other wearables and things that you can get that aren't necessarily FDA approved yet, but some things are coming, and we do have one from Amazon, so I could show you that too. But these are all just, oh, Canada? I'm not quite sure about that, but we can look. Yeah, for sure. Yeah. Awesome. Yeah, awesome. If you want to stop me afterwards, I can feel free to talk more in depth about these, but super helpful. And the LGS Foundation is really willing to help you get those things too. Thank you.
Great. Thank you. Thank you, Jeannie. That was fantastic. There's nothing like boots on the ground, right, for how these things work. So I'll go fast through slides, a bit of an overview of technologies. It's a very, very active space, which is a good thing, right? So there are a lot of new technologies being developed, but there are some challenges with that too, of course, as new things get developed. There's a bit of like what's best for the particular questions or for my child or adult. So I'll cover quite a few things. I do have just a couple of conflicts, but none around these topics that we'll be talking about. You guys know about epilepsy, and we've talked about this, just the comorbidity of Lennox-Gastaut and epilepsy in general, and obviously sleep and SUDEP. And I think for these devices, one of the primary drivers, of course, is SUDEP. And for the caregiver, how do you get a restful night's sleep? And I heard a yeah from Jeannie. So this, I think, is a big driver, both for children and for adult living with epilepsy. So I'm not even going to go over this, but there are new devices and older devices. There's a whole space for intracranial neuromodulation, a therapy. This is what a large part of my practice is. You know about VNS, there's DBS, and responsive neurostimulation. But what we primarily want to cover today are these both wearable devices, and there's what's referred to as a minimally invasive device for recording EEG that's just come on the market. So they're FDA cleared, two companies, Epiminder and Uni-EEG. It is a surgical procedure, but it's where you can get continuous EEG recordings from patients. This is something that's going to be an evolution. We'll see more of this. There are certainly plenty of applications. We heard some today about how do you know when you start a new drug whether it's working or not. You know, how we currently treat epilepsy is you try a drug, and how do you know it failed is, well, not until a seizure occurs. So they're in the future, there'll be more information and more intelligent ways of determining that. So, but as far as just non-invasive, fully non-invasive, the Empatica watch. Does anyone use the Empatica watch here? Awesome. So a couple.
I'm not thrilled with it. Especially since they made it switch from the Embrace to the Epiminder.
Uh-huh. What's the, and that's exactly what I would, anything, questions, this is pretty open. So that's great. What is the primary problem that you have with it? Is it false positives or?
Yes. No, but actually, my daughter now lives in a facility for a few years.
Uh-huh.
You can't remotely access it anymore. You used to be able to access the Embrace watch.
Yeah.
You can't. So I had to go there to her facility and ask her watch to send me, to email me the
Yeah.
information.
Yeah.
And that's the only date I get.
I got
for
you.
her appointment.
Yeah. So that's very useful information because those are just, I like to say, just engineering problems, right? So there are science problems which are really challenging. What's the cause of the disease? But some of existing problems are engineering problems, meaning the technology exists. It just is a concerted effort from people living with the disease, driving how the next generation of these devices will work. I thought you were going to say false positives, because Jeannie and I were talking about this, and a false positive, that just means any device that detects something, you want it to detect seizures, for example, it detects other things. So if it's something else, that's a false positive. And if that's happening in the middle of the night and it's sending a caregiver alert, that's pretty disruptive. So
Also, what we found is we know she's having a tachycardia. She's in the room with us.
Yeah.
And it does not detect it
yeah,
because it's like 23 seconds rather than 25.
Yeah.
So I wish they could improve the time on that, and also the ability to detect the different types of seizures,
Yeah.
because the grand mal seizures, the
Yeah.
tonic-clonics, were the only ones that the residential home was detecting
Yeah.
because they're loud.
yeah.
To get one that would detect the
Yeah,
tonics would
so
be
that's-
even better.
That's a great point. And you'll see in the summary slide, there's not a technology, other than these devices, other than these devices that record EEG, there's not a wearable device currently that will detect non-movement related seizures. So a pure absence seizure, there's not a device to detect those.
Do they detect heart rate?
They can detect heart rates.
Saying detect shaking, but I mean, for us, I know for sure if her heart rate's elevated.
Yeah,
one.
yeah. So they have a couple of different types of sensors, but electrodermal activity, it's a galvanic, it's basically sweating on the skin. Some signal there, heart rate, but a lot of false positives with those
I imagine
measures.
so, but I mean, we get false positives with the SAMI as well.
Yeah.
And when it says caregiver alert, what does that mean? It's gonna beep on its own in the room, or is it gonna send me something on my phone?
Yeah, so it can go, different devices do different things,
Okay.
right?
Okay.
So some don't have actually the connectivity via the internet to your phone, but some do.
Okay.
So the SAMI will just, it uses an SMS kind of service, so it can give you an alert, but it's not via your smartphone.
It is the smartphone that's dedicated that you have.
Just to that, yeah. And you can do that on your iPad, I think, as well, if you have an iPad or a phone. And then there's the Epi Watch is another common one. And this is actually a fair amount of real-world data has been collected with this. This is just based on the Apple Watch. So you have to have an Apple Watch, the motion sensor, and then it's an algorithm, that app that runs on the watch, again, to detect shaking seizures, motor seizures. Yeah, is anyone, yeah, thanks, it's a good question. The Epi Watch, anyone using that? Yeah, so a fair amount of data has been collected with this device, the Epi Watch. Again, it's an app that runs on your iPhone and your watch for shaking seizures. So these are all FDA cleared, meaning there's adequate data for demonstrating effectiveness. The other is this Night Watch. So it's an armband, again, detects shaking motor seizures and uses heart rate as well. This is, I think, was developed in either Denmark or the Netherlands, and it looks pretty promising. I haven't used it, but at least the data that's coming out of the European trials look pretty good for that. This is based on either an Apple Watch or an Android watch, so very similar to the Epi Watch. I don't assume anyone's used this device either. But these are, again, a lot of app development around existing technology. So it's something that's going to be more widely available. They're going to get better. We talked about false positives. That's what you want to know, right? The sensitivity and the false positives, detecting a seizure and how often it'll tell you there's a seizure when there's not. They're all motor seizures.
I would rather it tell me, though, that it thinks it, oh, I think she might be having a seizure and it not be, than
Yeah.
have it tell me nothing
Yeah.
and miss one.
So from an engineering perspective, you just make it high sensitivity and live with more false positives. So there's a lot of tuning, I think, with all these devices that you can optimize. That'll be different for different patients. This is a mattress sensor under the mattress for movement. And then we heard about the SAMI. And I told you, I just sent out a survey to my pediatric epilepsy colleagues and say, what are you guys are using? I don't want to sound like a marketing thing for SAMI, but they all tell me this is what they feel is the best. A lot of adults, I think, more use the Empatica, and I'm finding more people using the Epi Watch. It's pretty simple. Again, you just have a prescription for this Apple Watch and phone. Again, detects a detection algorithm based on motor movements and heart rate. EpiPal, similar. So I think you get the thread. They're the medical electronics moves incredibly slowly. So these implanted devices and stuff, it just takes a long time. There's a lot of regulatory piece. There's a little bit of a sweet spot here, but the challenge is, because these are really piggybacking, if you will, on commercial products. And commercial electronics, nothing moves faster than commercial electronics. You know, your iPhone you have today is not the iPhone you had 3 years ago. You know, it's got a better battery, it's got more memory. So that's why I'm optimistic, and I think that these technologies will just get better and better. So just a little bit about the more invasive technologies, which were, and these are available in the U.S. currently, EpiMinder and Uni-EEG, but are continuous EEG products. So but it involves a surgery. So it's a lead that's underneath the scalp. It's a derivative of a cochlear device. So there's two of those. EpiMinder's one. It's an Australian company, but they're in the U.S. now. And then the Uni-EEG device. So the companies like to use the word minimally invasive. They're less invasive than a full intracranial implant, but they're, you know, it's still a surgery. So I just this is just a summary table. I want to keep track of time here. So, yeah. And I can share this with you, but basically it's the ones that we've talked about. The physiology, so they're all based on physiology, mainly motion, heart rate, this electrodermal activity from autonomic symptoms. I think the most of the success and wide use is with nocturnal monitoring of motor seizures. This is a big need, a big clinical problem, and what I hear from people that this is something that's very, very, very useful for them. We have two pulmonologists to speak, so I'm not even going to say anything about pulse oximetry, but Jeannie mentioned pulse oximetry. But again, motor seizures, big gap for non-motor seizures. Technology doesn't exist other than something based on EEG that's, again, more invasive. So maybe what the future looks like, the idea that you have these technologies tracking patients, the idea that you can stage sleep, for instance, from these technologies, track seizures, and then what I think we'll see in the future is the idea that you can tie these technologies to the delivery of medications. And so I'll just tell you quickly about a trial that we're currently doing with one of those sub-scalp devices. The idea is so you can detect seizures. It's continuously streaming EEG that comes onto a handheld. And then if you can forecast risk for seizures, there's been as all of you, I think, are going to know, is the new medications, rapid delivery of medications, intranasal medications. So I think, again, these technologies will come together and I think have a chance to really have a big impact on how we manage people living with epilepsy. So, questions or other thoughts? And you have, I think, all the tables have a sheet. So just input. It's interesting. We did it piece by piece. So who's using a seizure detection device at home? And is that, I heard Sammy, or most people, Sammy, yeah. All right, well, I'm going to hand it off to my colleague, Dr. Gupta. This advances, that goes back, and that's the laser pointer.
Gotcha. All right. Thank you, Greg. All right. Hi, everyone. My name is Geeta Gupta. I'm a pediatric pulmonologist and sleep physician. So thanks for inviting me into your space. As someone who's not a seizure doctor, it's a privilege to be here and, be able to hopefully answer some of your questions and share some information from a sleep and lung perspective. All right, so I think all of you know the answer to this. Why do we need to, monitor sleep in people with epilepsy? Well, we know clinically people who have sleep disorders will have more seizures. There's an increased SUDEP risk. And also, we've heard so many times throughout the talks today how impaired sleep affects quality of life not only for the person with LGS, but also for the people taking care of them. So it's really important that we think about long-term sleep monitoring and solutions for both the patient and the people taking care of them. And then from a research perspective too, it's really hard with some of our sleep studies, which are just one night, to get an accurate understanding of what's going on with someone's sleep, right? Who here thinks that has anyone's child ever had a sleep study here in the room? All right, so pretty much everyone. And do you think that was a normal night of sleep for your child? No. Okay, and so, it's hard to understand sleep of people with LGS if we're not actually capturing them when they're having an abnormal night of sleep, right? So it's just not bad information, but it's not necessarily the best information if we really want to understand what's going on with your kids when they're sleeping. And so we want to see if modifying sleep can change outcomes, but are there things that we can modify to improve sleep as well? So it's important that we think about some of these wearables, even though all of them are imperfect, and I will go over all of their imperfections, but maybe some of their promise as well. And so, like I said, I'm not going to be everything that I say you should take with a grain of salt. You know, there are many pros to these devices, there are many cons to these devices, and like Dr. Worrell was saying, they're changing so rapidly. So this is really a very brief review of representative devices. So I basically chose things from different categories so that you can get a flavor of what's out there, but this is by no means comprehensive, and there are many examples of devices in each category. So I just chose one that I know of, or just one that I found, so I don't have any favorites either. All right, so here I'm going to go through these quickly because I want to, and also feel free to interrupt and ask questions too. This is supposed to be a casual conversation. This sleep study, it sounds like almost everybody's familiar with that. This is our gold standard of sleep testing and sleep medicine. So as all of you know, it's a lot of different sensors. Nothing hurts, but it's really annoying, right, to have all these sensors stuck on you. It's very disruptive. So there's EEG, which captures sleep. We know sleep comes from the brain. That's stuck onto the scalp. Everyone in this room is familiar with EEG. There's a nasal cannula type device, which measures airflow from both the nose and the upper airway. There's a little tiny sensor called a thermistor, which measures airflow there. There are these tiny seatbelt type devices too on the chest and abdomen that measure the effort of breathing. There's also pulse oximetry. I know someone had a question about pulse ox. Basically, that's measuring oxygen saturation, which is an estimate of the oxygen levels in the blood using light. So again, that doesn't hurt, and that can be something that's useful both, you know, clinically, but also at home for some people. And then we have a limited EKG, which looks at heart rate, and then sensors on your legs and your chin that look for abnormal muscle movements. We can also have home sleep apnea tests, which I'll talk a little bit more about tomorrow. These are basically, it's like a streamlined sleep study. So it has kind of the bare bones of a sleep study. It doesn't have everything. And importantly, most of them don't actually capture sleep because most of them don't have EEG, whereas nowadays, though, there are some home sleep apnea tests which do. Again, the landscape just keeps on evolving, so, but, you know, the typical home sleep apnea tests don't measure sleep technically. There are some home sleep apnea tests which use surrogates to measure sleep. So they look at autonomic functioning, so things like heart rate, things like how constricted or dilated your blood vessels are. So this device that I have a picture of is called a watch pat. Basically, it measures the amplitude of the capillaries and estimates sleep-wake staging based on that, movement, heart rate variability, and so on. So there's so many different technologies, and they're all evolving. And then you can have very streamlined sensors, too. So, for example, this is the Sleep Ring, I believe. It's by Sleep Image. Again, I'm not advertising for them. That's just what this one happens to be. This one uses cardiopulmonary coupling. So basically, it looks at changes in heart rate variability. It also assesses your movement during sleep to estimate your respiratory rate. And, you know, we have different breathing patterns when we are in different stages of sleep. So when we're in deep sleep, for example, you have a different, more irregular breathing pattern than when you're in, say, non-REM sleep. So that's how that works. And then, you know, since this is a focus on sleep and epilepsy, you know, in-lab sleep studies, which is the gold standard, it can assess everything. It can assess sleep, sleep apnea, you can capture seizures, but it has many drawbacks, which we've talked about. Most of the other, actually all of the other home sleep apnea tests are not indicated for seizure detection, but they can capture sleep apnea, and then some of them can estimate sleep staging, but the technology really hasn't caught up to the guidelines from the American Academy of Sleep Medicine. So in our, you know, scoring guidelines, you're not going to see how do you score these particular devices, but technically the physiologic signals are there, and so we can kind of make an estimate on the sleep stages as well. So then there's a category of other wearable devices. So on the right side of the screen is the ActiWatch. So this is called actigraphy. This is more of a research grade equipment, and basically it measures in 3 different planes movement, and by understanding how a person is moving, it's able to estimate whether someone's awake or asleep. It does not estimate sleep stages. It has a lower frequency of data capture than the more commercial devices like the Apple Watch, for example, but it's what's been used in research for many years. It has pros and cons. The pros are it's very established. Cons are, though, it's actually not being produced anymore, and the software is no longer being supported, so that's a con. And so it's not something that a patient can really reliably use in their home, even though this device has been used in a lot of research studies. There's other devices, for example, this is the Oura Ring. It uses photoplethysmography, so it uses changes in light signals to estimate, changes in heart rate, movement, and that's how it's able to stage sleep. There are other things that are not ring-based or watch-based at all. For example, this is a hexoskin vest. So from what I read, it actually was initially used to monitor heart rhythm, and this device now has expanded to estimate sleep by looking at changes in movement, but also estimate seizures as well. So it's, I think, a good thing for people with LGS or families of children with epilepsy to know about this type of device as well. So here's a summary of the 3 different types of devices. Of the 3, only the Hexoskin Smart Shirt or that smart vest has been studied in seizure detection. The other 2 devices really are more sleep-focused devices. And then another category of sleep devices. So Dr. Worrell talked about this, the Empatica, which is really focused on seizures. There's very streamlined EEG that people use at home too. So for example, behind the ear EEG, subcutaneous EEG, and even headbands. So for example, this Dream headband has been used in studying both sleep and seizures. So the Empatica, you all know more about this than I do, because it sounds like you guys have some experience with this. It technically can, as of 2026, estimate sleep stages, and it's definitely, I think, been more developed for seizure detection. The Bitefly sensor dot technically can stage sleep, and it has had kind of poor reliability for doing that. Again, it's more of a seizure detection device. The subcutaneous EEG actually did pretty well for staging sleep and also is primarily a seizure detection device. And lastly, the Dream headband, like I said, that one I've seen more used for both sleep and seizures. So I'm going to stop there before moving on to the next set of slides. Do any of you have experience with even some of these commercial devices, for example, the Apple Watch, or that those seem to be very popular, or some of the more seizure-focused devices?
I work in a primary care provider's office, and I know when sleep studies are ordered, most often a home study is required first. How does that, they're not as detailed, right, as an in-lab study?
That's correct. So is your question why,
Well,
why is that?
Would
Or-
one of our LGS loved ones benefit from just skipping that step and going right to in-lab, or would they have to do an in-home?
That's a very good question. I think it depends on the age of the person with LGS. So for children, we're able to, actually in children right now, home sleep apnea tests are not indicated at all. So it's, some parents want to get their child a home sleep apnea test, and it's difficult to do that. For adults with LGS, it's jumping through insurance hoops, I would say. So some of the situations are kind of absurd, right? Like if we know we're not going to capture certain information with a home sleep apnea test, do we have to really do it? The answer is yes, because otherwise the in-lab sleep study doesn't get approved. So whoever is reviewing the insurance claim just wants to see that the home sleep apnea test failed or there was an issue with it, which is interesting because having neurologic conditions such as seizures are technically a contraindication for most home sleep apnea tests, but it's just the rules of the insurance company. But there's really no medical reason why you would do a home sleep apnea test first. But I will say there could be reasons why you might want to have a home sleep apnea test. So maybe your child is sleeping better at home. Maybe they didn't tolerate the in-lab sleep study. Maybe it was hard to get to the sleep lab and sleep in an unfamiliar place. So I think there's pros and cons, but why would you be mandated to have a home sleep apnea test first? That's just the insurance rules. Hi.
So I have an 8-year-old daughter, and she recently had a sleep study, and they detected that she has sleep apnea. And so now we're in the process of getting the referral for ENT to explore the option of having her tonsils removed, because apparently she's not a candidate for a CPAP machine because she has a higher risk of aspiration. So now I'm kind of wondering, could this be linked, or is it like the chicken before the egg? Could she be having, because primarily her seizures are nocturnal, could the sleep apnea be causing the seizures or the seizures causing sleep apnea? What's your experience with that?
That's a great question. I think either could be the case. So we know that disruptions in sleep can increase your risk of having seizures, and sleep apnea disrupts your sleep, both by waking your brain up, but also by lowering your oxygen level and having different effects on other organ systems of your body. We also know that sometimes people have apneas or they stop breathing briefly after a seizure too, depending on the person's type of seizure and what happens with that particular person. So it's really hard to say. The apnea that happens after a seizure is not sleep apnea technically. So the treatment for that type of apnea would be to treat the seizure. Whereas if it's an issue with the airway not being fully supported during sleep, or if there's a mismatch between the signals between the brain and the body, and that's central sleep apnea, that's also treated with CPAP. That's a different issue. So they're related, but not the same. And then I think your question was also about adenotonsillectomy instead of CPAP. That can be helpful for a lot of children. In terms of aspiration risk, so typically for our patients, especially our pediatric patients, but all patients really with epilepsy, we prefer, if they're going to use CPAP, that they use a nasal mask. So we have lots of different nasal mask options, even for little kids, even babies. Nowadays, the mask options are just getting better and better, but we prefer a nasal mask because that lowers the risk of aspiration. That way, if the child has to vomit, they can at least vomit out of their mouth and not have pressurized air forcing the vomit back into their airway. But definitely, I would say if you were considering CPAP for your child, a nasal mask is the safest option. But adenotonsillectomy, also just to finish that thought, not only can it treat sleep apnea, but even if there's partial treatment, that's a big win. And for some children who need to use CPAP later, oftentimes those children need a lower CPAP pressure, so they're able to tolerate the CPAP a lot better.
Okay, perfect. Thank you.
In general, in my practice, extremely low threshold, like no threshold for a sleep study to look into the possibility of apnea in anyone that's still having seizures despite being on medicines. So good job figuring that out, because yeah, no question, it will exacerbate seizures. So, but just in general, if you haven't had a sleep study, again, I would say a low threshold for if your child or adult's still having seizures. Yeah.
Thank you. Is it on? Yeah. My daughter was only diagnosed at 34, although it was clear she had seizures. But I know that she has sleep apnea, and I just found out a year ago. It never really occurred to me, and she also has, well, we call it myoclonic jerks at sleep, but perhaps she really is, I think maybe, I don't know if, I never even heard of monitoring during sleep. I don't know if I've been, because of my ignorance, not taking the best care.
41 years old, just ran in front of you.
That's what I want to know.
It's kind of true. I have it.
So I think monitoring sleep is much easier said than done. I don't think you should beat yourself up about it. Even sleep doctors have. I have a colleague whose child had florid sleep apnea, and she realized when he was 5 or 6, and she's like, "Oh, I can't believe I never realized this." And this is something she does day in and day out. That is her only professional job. It's much easier said than done. Also, children aren't like adults who may have really loud snoring. You see huge pauses in their breathing. Sleep apnea can be very subtle in children. That's why you need a sleep study to detect it if you suspect it. Children have a more intact upper airway reflex, meaning their muscles support their airway in response to aberrations in upper airway resistance. And so you have really subtle collapses in the airway is basically what I'm trying to say. So I don't think you should beat yourself up about it. Kids also don't snore as loudly as adults. Some of them do. I mean, probably many children in this room have loud breathing and snore really loudly. I'm not saying that can't happen, but I'm also saying that it could be the case where your child is snoring softly or just sleeping with their mouth open, and you don't see those really overt pauses in breathing. So I think the fact that you got your child diagnosed and tested is great, and it's really hard to detect sleep apnea, especially when you yourself are sleeping. It's not easy. Any other questions, or did anyone else want to share their experiences using a wearable device or technology to measure sleep?
Our son had a sleep study that was not good because he had seizures all night long, and then he had another one. Well, in that first one they said, "Oh, he definitely has sleep apnea," and I said he had seizures all night long, so it was not valid. Then his second one, they said, "Oh, it doesn't really look like he has sleep apnea," but he sleeps with his mouth open 100% of the time. His mouth is so dry, and there's snorting. But we're just like, if I go in and close his mouth, it's like, oh, he breathes so nice, but I can't hold his mouth closed all night. Are there any good devices to help with that?
That is a great question. So there are a few things to unpack there. There are many different reasons for sleep apnea. One of them is neurologic tone, right? So our brain controls all of our muscles, including the airway muscles. And so you can have a lot of night-to-night variability. You could have a great night at the sleep lab or a terrible night at the sleep lab, and we just do our best to understand the overall pattern. And especially in a child with LGS, depending on what medications they're on, how well their seizures are controlled at any given point, your sleep apnea could look different. at different times. And then in terms of something to just keep the jaw closed, there aren't great options.